This is sort of like popcorn, right? When they stop popping in, then you begin to, you say, all right, now there you go. There we go. Look at this. Well, we've got a nice crowd and it looks like it's they're still coming in. So, but I'm committed not to steal more than 5 minutes of your hour. And my name is Peter Orris, for those of you who don't know me, and I'm a professor here at the School of Public Health and of Occupational and Environmental Medicine at the medical school. And been with this global initiative since it began. I'm supposed to remember to remind all of you, there is no meeting next month, but this is a monthly seminar, and anybody that's new to the seminar has a whole host of both in-person and virtual very exciting speakers. So that's my advertisement for us on this. Let me also begin with another short thing. It's really growing in its acceptance now, the land acknowledgement, and I find it very good to start with. And as a land grant university in the Midwest, I think it's important for us to do such. So I would just say, in brief recognition, that the Chicago area is located on ancestral lands of indigenous tribes, such as the Council of Three Fires, comprised of the Ojibwa, Odawa, and Potawatomi nations, whose members were often forcibly pushed from these lands by wave after wave of involuntary immigrants from Africa, Europe, Latin America, and Asia. The traditions of these indigenous tribes and these immigrants, both paid and unpaid labor, has built the multicultural, multiracial civilization we now try to enjoy today. So that's my modification of the acknowledgement. And it is a real pleasure to bring you today Dr. Shada Rouhani from Boston and from the Harvard system. Dr. Rouhani is one of the current leaders in this generation of leadership of Partners in Health. And for somebody who knew and strongly admired Paul Farmer, the original conception and founder of Partners in Health, it's a real pleasure to be able to introduce this generation of leadership for this organization that has made such contributions around the world, and in an era of increasing attention to decolonization, if you will, of global health, has played such an early role in this. Dr. Rouhani is an assistant professor at Harvard of emergency medicine, primarily at Brigham and Women's Hospital, where she did her emergency medicine residency after graduating WashU in St. Louis, and coming to us as a gift from McGill, perhaps where her breadth of global interest arrived. She did a master's in public health at Harvard School of Public Health after her residency, and as I indicated before, is now assistant professor. Now, one of the daunting tasks here, and I'm going to stop at this point, seeing my 5 minutes is up, to introduce someone like her is that when you look at her accomplishments, it reminds you of the old quip from Boston that it was humbling to note that when Mozart was my age, he was dead for 5 years already, and her accomplishments are extraordinary, And at this age, and at her age, even more so. So I can't say any more than that. And welcome. And we're so happy that you're going to be spending an hour with us. And we have many questions for you. You're on.
Thanks so much. And now that I'm blushing, we can go ahead and I'm happy to get started. But thank you so much for the introduction. And thank you guys for having me here today. I know that we are virtual. I would like to be able to answer as many of people's questions as they have. So please, I encourage you to drop any questions as we go in the chat, and we'll either try to answer them as we go or at the end. But pleasure to be here with you. As Peter mentioned, my name is Shada Rouhani. I work both clinically at Brigham and Women's Hospital and at Harvard Medical School in emergency medicine, but then I work a majority of my time with Partners in Health, where I direct our emergency care programs and our disaster preparedness and response work. And that's the perspective that I'm really going to be focusing on and bringing with you today. So first, no disclosures, no conflicts of interest to report. Just a quick overview of what we're going to talk about today. So I'm going to spend just a few minutes talking about what we really mean by NGOs and NGO type roles for careers. And then I'm going to spend a little bit of time just giving some background on how I've ended up where I have and the variety of roles that I've had along the way as sort of an illustration of the different types of ways that you can engage with NGOs over time, and also an illustration of the fact that it doesn't have to be one thing for the rest of your career, and that frequently these paths do change. And then spend a fair bit of time talking about just tips and tricks when you're thinking about working with an NGO. What should you be asking about? What should you be thinking about? And what types of things do we look for from the perspective of an NGO looking at academic collaborators in the global health or public health spaces? So first of all, just to acknowledge, this is a really diverse topic. NGOs are not one size fits all. There is tremendous diversity, both in terms of the size of the organization, where they work, and also just in terms of the complexity and the formality. Some organizations are strictly local and work in only one place, one country, one region of a country, one town even. Others are multinational and span across 40, 50, even 100 plus countries. And so when you're talking about NGO work, there is a wide range of what it can look like, but there are some common themes that apply. The other related diversities come down to mission. So every NGO has a specific focus of their work. Within the health sphere, I sometimes think this helps to focus on things that are either humanitarian response focused, so really targeting emergencies and disasters, versus organizations that are more developmentally focused. And then funding sources vary. So some organizations are primarily grant driven or foundation funded. Others are primarily funded by individual donations, some by small donors, some by large donors. All of that is going to translate into differences into what NGOs like to fund and what they like to work on. I know not everyone here is clinical, but for the clinical side of things, and I think you could make similar arguments on the public health side. When you think about working with an NGO, I like to bucket it in 4 general groups of ways that people work. And so one way that people tend to interact with and work with NGOs is as a clinical service delivery and/or educator. And these can be either short or long-term roles. And they can be primarily clinical and care delivery focused. It also can be primarily education focused around training or teaching clinicians or public health experts at the site or the location that the NGO is working in. A related but separate way that people can interact is really as a technical expert on a specific program. So this could be, for an example, as a maternal child health expert, as a ICU expert, as an infectious disease expert. These tend to be more short or medium term roles, and they focus on a very specific clinical or programmatic area where the NGO may be expanding into or looking for additional expertise when thinking about how to design a program. And those roles can be variable, but often include some component of clinical care delivery, educational support, and/or programmatic aspects to them. Then the third bucket I would put things in is really working on implementation programs. These tend to be more medium and long-term roles to work with NGOs, and these are spanning beyond direct care delivery or education into all of the aspects of running a program. So how do you design a program? How do you implement it? This can be working on one aspect of that, or it can be broader as managing an entire program for the NGO and working with a group of people to support that program. And then the final bucket that I bring up is as a collaborator. And I think for many people in academia, this tends to be how people interact with NGOs. And this can be working where your primary home, your primary focus is in your academic role, but you may collaborate with NGOs on specific projects. This tends to be where you have an independent project or program, but you may have either a formal or informal collaboration with an NGO, where that might be the site where the program takes place. It may be that you work in a similar location and occasionally collaborate on things. These can be very formal collaborations that have MOUs governing them. They can also be more informal relationships. And spanning across all of these, I just want to note that when we talk about from the academic perspective, research or academic work, that it really can apply in any of these buckets. And so I want to stress that just because I think particularly for people early in an academic career, sometimes there is that pressure of how does that fit into work that I want to do? And I have seen that successfully incorporated into all of these different ways of work. So we'll come back to some of these buckets in a minute. I, over time, have worked on a number of these different things. And so, as I mentioned, I'll tell you just a little bit about my journey to kind of give some perspective of what some of these roles look like and what I've learned over time about these roles and what I wish I had known, 10, 12 years ago. As I mentioned, I work for Partners in Health, and we are primarily a social justice and healthcare organization. We have 11 healthcare delivery sites around the world. We work everywhere we work with the government and the national governments. We work in long-term relationships, and our focus is always to provide care for the most vulnerable patients. Over time, I've come to work in a number of our sites, but my work initially started in Haiti. I mentioned that all organizations have a mission, and this is PIH's mission. So we are primarily a social justice organization, meaning that we are focused on how to kind of expose and improve the injustice that really does lead to a lot of poverty and worsened health outcomes. And we do that through medical work and medical care. And so improving access to healthcare, improving healthcare opportunities and quality for patients who traditionally have been excluded from those healthcare systems. And as I mentioned, I first started working in with PIH in Haiti back in 2012. And at that point, I had primarily experience more in the collaborator bucket, where I had worked on shorter term global health projects in a number of different countries, typically as a collaborator with a different organization, more in short and medium term programs. And I really wanted to get some focus on and some exposure to health system development and health system strengthening. And so I initially started working with PIH in St. Mark in Haiti, and then worked to spend a number of years in Mirebalais and central Haiti. And when I first went to St. Mark, I went to this hospital, which is Hôpital Saint Nicolas. It's a public hospital that PIH supports in the Artibonite region of Haiti. And there they had a small emergency department that was developing. And I first went in a very clinical and education role. So that first bucket that we talked about. So at that time, I was really focusing on supporting the education of the nurses, the physicians, providers who were there working at the hospital through lectures, through bedside teaching, through some direct clinical care delivery. And then over time, that evolved into more of the slowly starting to dip into that implementation bucket. And so after several months, I was asked to start working on very small quality projects. And then those slowly expanded until after around about a year, I transitioned to working on the opening of Mirebalais University Hospital, which PIH was opening in central Haiti. And to really understand what that project was, it does help to go back a couple of years. And many of you will remember the 2010 earthquake that was really devastating in Haiti, killed over 200,000 people, displaced countless more. And it destroyed the medical infrastructure and the medical education infrastructure in Port-au-Prince, which at the time was where all the medical education infrastructure had been focused. And so in the aftermath, as the government was beginning to think about reconstruction, one of the things that they wanted to prioritize was decentralizing medical education and decentralizing medical education infrastructure. And that's where PIH came in as a long-term partner to the government. So we had been working in Haiti as an organization for decades, starting in Conj on the left here, and we were already helping to support the government with building smaller hospitals and clinics. And after the earthquake, they made a specific request to PIH to help build a large academic teaching hospital about an hour and a half outside of Port-au-Prince. And that's where HUM came from. So Hôpital Universitaire de Mirabelais, it's a 300-bed academic teaching hospital. And in early 2013, where I started working there, the construction was nearing completion and they were just starting to hit this phase of planning for operations. And so I was officially brought in with a role of helping to plan the emergency department and plan the emergency department operations, thinking about how do we start a system of triage where it hadn't existed previously. But unofficially, the job was really getting whatever needed to get done. And we'll come back to this later. But that ranged from everything from sorting supplies on wards, making staffing schedules, helping mock up patient flow in the outpatient clinic. And this is really where my role started to switch a lot more from that clinical care delivery and education role into a lot more of an implementation focused role. And so the emergency department opened in June of 2013, and it never has looked as clean as it did on this day when that very first patient came in. And at the time when we opened with 24/7 capacity and dedicated physician staffing. We could talk another time about how to open a hospital and how to open an emergency department, which is a whole topic in and of itself. But over the next 5 years there, I spent a lot of time thinking about and learning how to help strengthen and build a health system and an emergency department. And what I've figured out over the years since is that while I initially found it really hard to describe to people what do implementation roles look like, I find that these buckets, which is what we often use to think about how do you strengthen a health system, these 5S's, 4 of which are shown here, they're also the ways that you help think about implementing programs, whether you're talking about clinical programs or elsewise. And so these are the areas that I spent a lot of time learning about and learning and designing programs around. So thinking about staffing, how do you ensure that you have trained human resources at all levels, nursing, clinicians, auxiliary staff? How do you think about scheduling and staffing and logistics to make sure that they're there at the right times? Thinking about the spaces, what does the physical infrastructure look like? How is it laid out and designed so that you can accomplish the aims of your project? Thinking about the stuff, so the medications, supplies, the biomedical equipment, oxygen, and then finally the systems. And that ranges from everything from very clinically focused systems like triage, result reporting, movement of patients, to things that are more maybe in other realms like medical informatics systems, referrals, and communication of information between inpatient and outpatient care. And this, I find that the 5th S that we don't have labeled here is social support, but I find that this 5S rubric really is helpful both in thinking about how to do health system strengthening, but also when you're imagining taking on an implementation role or an implementation project, a way to conceptualize the different types of things that you may need to do over time. And so as I mentioned, I spent the next 5-ish years in Haiti at Mirabelais, and during that time, had lots of ups and downs, lots of very gradual and deliberate implementation of programs, but it turned into a new emergency workforce of providers. So we opened the first emergency medicine residency program in the country. And in 2017, that first class, which is these 5 doctors in the center here, graduated. And the department transitioned over entirely to local leadership, initially with Dr. Linda Rampel, who you see on the left here, who took over as the program or the department chair, and Dr. Cassandra Edmond on the right, who took over as the residency director. And around that time, for me personally, 2 things shifted. One was that I wanted to start looking at work in other locations, to start thinking about how do these programs scale and work in other places. And I also, frankly, was at a point in my life where I needed to be able to balance a little bit more time in the US as well. And so over time, my role at PIH has shifted from a role of working primarily in Haiti to working to support all of our care delivery sites. And the countries boxed in orange here are places that I support around emergency care work. And those in yellow, I've supported primarily around oxygen work. What I've done in each of these places has been very different. PIH as an organization, we work where our local teams dictate what programs look like in those sites and what the priorities are. And so our job at a cross site, or what we call the coordination site level, is really around supporting those programs and helping them with those implementation and education and other programs. So what my roles have looked like have been everything from starting with general operations, thinking about formulary, biomedical equipment and protocols, to thinking about what do beacon healthcare facilities look like in these sites, to really focusing back on emergency care development across our sites, minor side detour for COVID with some domestic response work and global health protocols, to thinking about global oxygen access and use, and to where I am now around both emergency and hospital systems and disaster response. And one of the questions I get asked often is, why have I stayed? And I think this relates to what we're going to talk about next, which is why I work with NGOs. And there's many reasons, but for me, being part of an organization working towards a common goal is really important. This is a Paul Farmer quote: "The idea that some lives matter less is the root of all that's wrong with the world." To me, this sums up a lot of why I went into medicine, but also a lot of what we are trying to help chip away at with PIH. And by working with PIH and working with an NGO, I feel it's a way that I can personally magnify my own effect, because there really is a whole huge number of people kind of working all towards this common mission and goal. And I personally value that quite a lot. So what have I learned over this entire time, and what is relevant to you guys as you think about whether to consider working with an NGO or not? First question is, do you do it at all? And I think this is something that when you're in academic global health or public health, it's a question that a lot of people come across. And I think it can be really useful to work with an NGO in the sense that they can help contextualize. They have worked in whatever location you're looking at for a long time generally, and they understand what has happened there previously, what is likely to work in the future and what is likely to not work in the future. It's an opportunity for you to plug into existing teams rather than needing to build your own team. They can help facilitate introductions to different other partners or organizations. They can support logistics. And importantly, your work can fit into a broader program, which sometimes helps with working towards that broader common goal or mission. It is important to know that NGOs generally cannot work outside their scope. They are obligated to their own boards of directors, to their own funders. And so when we talked at the beginning about NGOs have different missions and goals, you generally will not have a lot of success in convincing an NGO to do something that doesn't relate to their own mission. They also tend to be underfunded. And so generally they are not going to be able to commit resources to your project or forget about the long game in terms of the partners that they work with over time. If you do want to work with an NGO, choose the right one. So definitely look at the organization, look at the vision, look at what they've done previously, think about how what you want to do fits into broader programs. There is a wide range between local NGOs to international NGOs, and then organizations like PIH that kind of span both. We are an international NGO, but we are primarily locally driven and on a day-to-day level run by the local teams at each of our country sites. You want to ask any NGO you're going to work with, how do they interact with local teams and local structures? And I mean by that, governments, hospitals, ministries of health, other non-governmental and international governmental organizations. And then, does the job match what you want to do? And in particular with this, look at the field time. I've had a lot of people over the years who have expressed interest in wanting to work with an organization, but really aren't able to spend the field time that the organization needs. And that mismatch doesn't always work well. And so really looking at what is needed for the job and does that fit with what you are personally interested in, or would there be a different role that's better? And then finally, don't ignore logistics and safety. There's a huge range of abilities to support these things. Um, depending on the location in the country that you're working in, this may have a more or less importance, but always is important no matter the place. All right, so if you're looking at a service delivery or an educational role, that first bucket that we talked about, what types of things do you want to know before going into it? So these are the general questions I encourage people to think about and ask. So first of all, what's the clinical environment like? Who staffs whatever department? If you're looking at a clinical role, who staffs the department? Who will you be working with on a day-to-day level? How often do they rotate through, and how quick is staff turnover? What are ancillary services that are there or not there? This isn't to say you should take or not take a specific role depending on the answers to these questions, but you want to know what you're going into so that your expectations can be set and realistic to whatever it is there. Ask what role the visiting clinicians and educators have. I encourage people to look at roles where you are going to be working alongside local clinicians and really learning from them, and then helping to guide them in areas where they may not have not had exposure previously. What has made people successful or not successful there before? I think that can give you a lot of personal insight into whether it's going to match up well with your own skill set. And then how has it changed over time? I personally think you want to be in roles where you're working yourself out of a job. And so to me, going to a place where the role does change over time is a good sign that the organization is making lasting change and progress, and that those systems are sustainable. And then finally, if you're looking at a clinical or an educational role, just know that the length of your visit will affect your experience. And I really encourage people to spend as much time as possible, particularly early in a relationship with a site or a place. I generally find that for clinical visitors, it takes them at least 2 weeks to just become comfortable with the place, to learn where the bathroom is, to know how, who each person is, to get the basic sense of disease burden and what it's like. And I find it's the time after that that people start to really be effective in terms of teaching, training, mentorship, and in terms of understanding where there are areas of strength and areas of growth for the future. On the other side, what do we look for? So I spend a lot of time interviewing prospective clinicians and or subject matter experts or educational experts for roles at our various sites. And generally the things that I think about, obviously you need to have the subject matter expertise. We're not going to take you for a role if you're not qualified for it. But beyond that, these other things really come into play. So flexibility helps tremendously. Experience in low resource settings and or with the local disease burdens is a plus and greatly valued when there, although we definitely do take people without this when a lot of these other pieces click into play. I generally want to know about somebody's teaching experience and skills, whether in a low resource setting or not. How long can they be available for? Are you looking for a one-time interaction or a repeat interaction? And I will just say, please be honest here. I've definitely had people unfortunately not be honest in the past, and it ends up backfiring not only on that interaction, but also for other interactions from that organization in the future. And then what is somebody's personal goal for going? And then do they come recommended? And so if you are ever interviewing or discussing a potential role with an NGO, thinking of ways that you can demonstrate or show these skills, even if outside of the space that you're talking about, like if you've done a lot of resident teaching in the past or a lot of teaching of statistics to public health students, that is valuable. And we want to know about that because that shows us that you're going to be able to use those skills when teaching somebody else in a different environment. When you go, learn and observe, understand the structures that are there, understand who the leaders are, build relationships and friendships. And I can't stress this enough. I mean, these are the two department chairs that I showed you from Haiti earlier, and they're holding my 18-month-old son, who I would happily leave them with they do a better job raising him than me. Those relationships and those personal friendships go a long way into some of these other things down here, including understanding the place. And understanding the place is really what's going to make you effective and helpful. And so know what your own limits are. Whatever you don't know, learn. You're going to be able to learn a lot of that from the local teams that are there and from the providers that are there. And then when you notice something, ask why. And if you've built these friendships and these relationships, you'll be able to get honest answers to some of this. And then celebrate small wins. So this asking why piece, I emphasize a lot, particularly to people who are new to a place. This is something children are really good at, and that as adults we sometimes forget. But in Haiti, I'll give you the example of blood bank. So we early on had a number of visiting faculty members who would come down and who would get extremely frustrated with the amount of time that it would take the blood bank to deliver blood. And in one particular case, the blood bank had the blood ready, but they didn't have a cooler. And so they wouldn't release the blood because the cooler wasn't there. And the faculty member, I remember coming back incredibly frustrated about this because he's like, I'm just going to carry it down and give it to the patient. Why do I need the cooler? There was always a reason. In Haiti, there is a lot of historical prejudice that plays into the blood supply there. And as a result, the blood supply is very tightly regulated by the Haitian Red Cross and by others. And some of this relates to US policy back only about 35 years ago, I guess now. So in the early days of the HIV epidemic, you may have read or remember that the HIV epidemic was often branded in the press initially as a 4-H epidemic, with homophilia, heroin use, hemophilia, and Haitian as the 4th H. And that was an incredibly prejudiced view of the epidemic, and it led to policies such as a ban on accepting blood from Haiti-born donors. And this did trickle down into Haiti itself. And so some of the answers to these questions about why are really quite complex. And you're never going to convince somebody to give you blood without a cooler because they are dealing with the aftermath of a very long amount of time of sort of dismantling some of these policies and prejudices on top of all sorts of other things. And so really taking the time wherever you are to just ask the questions of why something happens the way it does, what has been tried before, really can go a long way to figuring out what is going to be successful in addressing problems that you do see. And then similarly, if you find yourself in a clinical role, my other big piece of advice is just celebrate the small wins that are there. I think sometimes going in a clinical or an educational role can be overwhelming at first because it can be very different than an environment you might have been used to in the past. And a lot of times human nature is to focus on things that we maybe notice as not effective or not good. And sometimes we lose sight of the smaller things that make big change over time. And so one good example there, again, drawn from Haiti, is around orthopedic care and splinting and fractures, broken bones. They're something that often are very healable, but if not splinted and treated correctly, can cause tremendous long-term disability. And something that seems small, like teaching people how to put a splint on correctly, doesn't seem at first glance to someone as obvious or as visible as a resuscitation that doesn't go well, but over the long term gets taught from kind of generation to generation and has a very sustained effect. So this physician in blue scrubs here is one of the senior residents teaching a new set of junior residents how to splint 10 plus years after it was first taught there. So just really focusing on those small wins can be helpful. All right, thinking about implementation roles. We talked a little bit about this before in terms of what those are. If you're considering an implementation role, things to ask there, asking about how the program that you're looking at working at, how does it fit into their other work? I find a lot of times you can get a lot of information by asking somebody, how did you decide to start a program? everyone has been in a position where we start programs because of funders, but ideally you want people to be starting programs because it's addressing needs that have been identified by the key stakeholders, right? The local teams, the local governments, the local hospitals, rather than something being launched because it's funder so that they were interested in X, Y, or Z. Who else is going to be working on it? What's the balance between local and international staff? Who is going to be able to support and mentor you? And it may be that you're looking at a small NGO who doesn't have the ability to do a lot of support or mentorship, in which case this then needs to turn into, can you get that support or mentorship from somewhere else? Is it resourced to be successful? Is it sustainable? And then can the organization consider all needed aspects? And those needed aspects can be broad. So just taking a quick example here of IV infusions, for anyone on who happens to be clinical or who has ever worked with an IV infusion before, just if you can imagine working in a place where you're starting a program to start being able to do IV infusions of, say, vasopressor medications or insulin or anything along those lines. If you can just drop in the chat for me 2 or 3 things, a couple of things that you think might be important to consider along the way. And we'll see if we can fill in what this might look like. Let's see if I've got anyone awake. Anything that might be important to think about as you implement a program with IV medications. Okay, infection prevention, great. So let's put that under staff education. What else we got? Appropriate titration, yep. So titration charts, proper dosing, so protocol development, waste management. I don't even have that on there. Skilled staff to start and manage the IVs, tubing and pumps, equipment cost and availability. So that is both the pumps, but it's the medications. And then as well, people often forget about what you have to dilute medications into. What else can you guys come up with? Labs to monitor, yep. Put that under protocol. Availability of the infusions, yep. All of these are true. Storage of supplies, yes. So medication storage for IV poles. Yep. Logistics for transporting all the supplies, exactly. So you can start to see the range of things that pop into play here. We haven't even hit on space and visibility for monitors, having monitors, forms to document dosing on, quality improvement work to make sure that everything continues to go correctly after it's implementing, mentorship for staff beyond the initial education, and reevaluation of patients after you first make an infusion change. So when I talk about making sure that a program is going to be resourced or that an organization has considered all aspects of an implementation program, these are the types of things that you want to look at and ask. Working with an NGO to implement a program, you've got to have something that's going to be able to look across all of these different areas. If you want to implement something with just education alone, it just won't be successful because you're going to be missing all of these other components. And even with all of these components, mentorship and support do matter. And like I said, that doesn't necessarily have to be drawn within the organization, but you need to figure out where you're going to get it from, if not within the organization. So this is noradrenaline. It's a vasopressor medication. This is a very recent example of where we got caught up after doing this for over a decade. We have our noradrenaline, we have our dosing chart. We thought all was fine to go ahead and implement because look, we've got a concentration right here on the bottle. All should be great, except for the fact that noradrenaline is actually often purchased, particularly outside the US, as a noradrenaline tartrate concentration, but the dosing is often done in the base concentration. So instead of this being 2 milligrams per ml, this is actually 1 milligram per ml of norepinephrine base. And so your dosing charts that you might pull may be completely different if you don't have someone to say, have you checked this against a couple of international drug dosing guides? And have you had a pharmacist who can help answer this question when it pops up to figure out how to actually make your titration charts? And again, if your organization, if the hospital you're working for doesn't have a pharmacist, it doesn't mean don't work with them, but it means you want to have somebody in your back pocket that you can phone a friend with to say, hey, can you help me think through this or look through this? So if you are going to do a program design or implementation role, first and foremost, know what skills you need and then go get them. It is a completely different skill set often than what you're taught in medical school or public health school. You need to do a lot more general management and project management. You're going to end up doing budgeting. You're going to end up doing a lot of logistics. I didn't know the term cold chain when I graduated from residency, and I probably use it 20 times a week now. Thinking about grant applications and donor relationships are all really important. Whatever your implementation role is, know that it's not going to be what you thought it was at the beginning. Things will change. You're going to need to be flexible as you go, and you are going to need to chip in elsewhere as you work through a program. All right, finally, the last bucket of work we talked about, working as a collaborator. So a lot of people in academia interact with NGOs in this bucket, where you may have a formal or an informal relationship with an NGO, where you work with them on a specific program that may be primarily a program that you run, that you collaborate with an NGO on. Sometimes the NGO will do the solicitation of the collaborators or subcontractors. Sometimes it may be that you approach the NGO with your own projects or goals. If you are deciding to propose a project to an NGO, please, please, please know your audience. Know what the NGO's goals are, their focus areas, and their place. Going back to the beginning of what NGOs cannot do, we generally are not going to work outside of our own focus areas. And so it's just going to lead to more success if you target who you're talking to relative to what the project you want to work on is. And then there's a lot that can be said for shifting your frame to say, I have a project you might be interested in, to go from that to, I'd love to hear about your work to see if there are areas or opportunities for collaboration. A lot of times the NGO's priorities may overlap with whatever your area of interest is, but understanding their priorities first and what has previously been done in that topic area will not only make the project more successful, but it's more likely to actually come to fruition as well. Realize that anytime you're talking to an NGO and proposing work, you are asking for a trade-off. And so do try to think about things from their perspective, both for the little stuff and the big stuff. And think about things from the perspective of they have been there for a while and they're going to continue to be there. And so how does your project fit into that? For perspective, when you talk to an NGO and say, hey, I want to come for 2 weeks to explore a project, oftentimes people expect the NGO or the local organization to help with food and housing for that. Not always, but often. But realize that the NGO's contributions are going a lot beyond that. So for just an initial 2-week trip on the low end, this is what I've seen typically go into supporting somebody to come. So there's some initial conversation that I may have with you that will then go to a broader discussion with our local teams, followed by some pre-trip orientation. We do a lot of work on the back end to support the logistics of that trip. Where are you going to stay? Even if you pay for it, we often do the reservations and the logistics of making sure that somebody gets from point A to point B. We orient you to the hospital when you get there. We do ongoing check-ins with you to make sure you understand what's going on, to answer questions that are coming up. At the very lowest end, that translates into somebody spending 14 plus hours with you and probably $1,500 plus. That's without any support for medical licensing. That's not with any specific meetings for your project, et cetera. And so if you think about your own schedule that you have in the US, do you have 14 hours and $1,500 to give to something that may not work out? And with that, what would your threshold be for giving that time and that money? And then keep that in mind when you're going to an NGO. So you really want to recognize what that burden can be like. Not to say don't approach them, but just to say make sure that you're approaching them with your homework done in advance. with understanding of what that trade-off is that you're asking them for and how might you be helpful in other ways while you're there. So if you want to go to explore a trip, is there something else you can help with during the time you're there? That might help offset some of this investment from their from their perspective. And keep in mind that while you may go with the best of intentions of a long-term relationship, that may not work out for some reason. And so an NGO does this multiple times with multiple collaborators for maybe one project out of 5 that actually works out. And then related to that, when I talk about the long game, just keeping in mind that NGOs are going to be, because you're asking that NGO to be helping facilitate introductions, the same way that you might debate who to introduce to your department chair, you wouldn't just bring any person you initially met to your department chair and say, hey, I've got this great person, they want to do a project. That same perspective holds true for an NGO with their long-term partners on the ground. If you are going to be proposing partnerships, I do encourage you to spend some time looking and reading about ethical partnerships. There's a whole bunch of frameworks that have been published in the last 4 or 5 years. A lot of them are more theoretical than practical, but these are some of the common principles that that multiple authors have identified as characterizing ethical partnerships and collaborations. And a lot of it relates to bidirectional communication, thinking about how our goals being identified, how our resources being allocated, how our contributions being recognized, and then how is a partnership being monitored and adjusted over time. So again, lots of great reading out there. I could do a whole nother talk on this, but I do encourage you, if you're going to be in a perspective of proposing collaborations or partnerships, to really spend some time digging into this. Right, and with that, I will stop there. Happy to answer any questions. Hope this gives some context or overview that can be helpful to you in your own career. And happy to answer any questions that are there.
Thank you very much for the overview and a lot of the detail and practical suggestions for how one would get into this area. I think we can take either raised hands or comments in the chat. And while we're waiting, you've held everybody on the line here for this period. Let me ask one just to start it off, and that is specifically looking at Kigali or looking at Rwanda. Marge Cohen, one of our colleagues here, who's now in Boston, does a lot of work with a group called UIC, and I know that from your biography, you're quite interested in the question of sexual violence during disruption during wartime, et cetera. And I'm wondering if there's any comments you might have on that project.
I'm not familiar with that specific project. I did a lot of work with that early in my career, and I haven't been as involved in that space recently. So unfortunately, I can't comment on that one.
Oh, well, hands from anybody. To raise your hand, you push the button at the bottom. So how do you handle the inequity in resources within the dynamic of who's making what decisions for moving forward? That seems to be a delicate area.
It is. It's a really delicate area. I think, to be honest, it's an area that we have adapted a lot on over the last 10 plus years. So the way a lot of our own programming, or all of our own programming, works now is it works around priorities identified by our local teams. So within any of our sites, there's a local governance structure of that will identify for the site what are the key programmatic, clinical, and other priorities. And from that list, we go out and deliberately look for funding around those areas and try to specifically bring in resources for those programs. you encounter a wide range of funders who want to give different degrees of acknowledgement or leniency in terms of what their funds are used for. And so it does sometimes mean working with funders to adjust expectations around what is realistic and what is not realistic, or advocating for different areas than what they may have initially wanted to fund. There are some funders that we don't use because of the degrees of ways that they like to dictate that funds are spent. And then I think the other piece too is when you can get a funder who is interested in a specific area, then helping both the funder and the local teams kind of work together to figure out what can overlap between different interest areas, because often you can find that overlap. I'll say we as an organization have also done a lot around one of the barriers to getting funding to local organizations can be around the support systems that a local organization has. And so really thinking about how to build up like accounting capacity and grant management infrastructure at a local level goes a long way to helping with that funding imbalance as well.
So we have a question on the chat. I don't know if do you see the chat?
Yeah, I do.
Okay.
Good question about looking for a job with NGOs. So I think a couple different things to look at. So certainly always helpful to check the general LinkedIn and various job sites. A lot of NGOs will have a link on their website to jobs. So thinking about what types of organizations you might want to work with and going directly to their website can be helpful. If you're not looking for a full-time job, but you're looking more for something that maybe is a short-term engagement, like a couple months of work, or for an intermittent engagement over time, where maybe you want to go to the same place to support a project a few times a year, I would say emailing the clinical, if you're a clinical person, emailing the clinical leadership, or if you're on a specific program, that programmatic leadership, to inquire about what sort of supports or help or opportunities they may have is always worth it. We don't, for example, personally, we don't always have opportunities, but every now and then we do. And sometimes we'll end up getting emails from people that just time well with those opportunities. And so it is always worth putting your name out there, and is always worth also just getting an initial conversation to learn what the organization does and what types of ways that they have used people in your own skill set before, because that keeps your name in the back of our minds. And then sometimes things come up in the future.
I give you the next one, chat. We've stimulated the hornet's nest.
I see here one about anything specific during medical education and residency that would have prepared you to work with an NGO. I think if you want to do implementation work, really getting those non-clinical skills is incredibly helpful. There are a number of courses I wish I had taken 10 years earlier, and they're not clinical courses. They're things around leadership skills, things around program management, program implementation, quality improvement work. All of that goes a really long way towards programmatic management. You don't have to get those skills in a global realm, right? There are lots of good leadership courses that may be local to wherever you are working, and they will give you skills and information that is helpful. You don't learn in medical school or residency how to give feedback to an employee. You don't learn how to do a budget. You don't learn how to do quality improvement cycles and how to make implementation plans and projections. And so all of those things are really helpful.
What about the language barriers?
Okay. So this is a really good question. It's incredibly variable depending on where you are working. And this is where having an honest conversation with the group that you're going with is really important. So In Haiti, for example, when we did the residency, the emergency medicine residency program there was no emergency medicine in the country. And so we relied extremely heavily on visiting emergency physicians who would come down to teach and train. Not all of them spoke French or Creole. What we learned worked best was actually, after trying to use translators and realizing that non-medical translators didn't work well, and that there were no medical translators available, what we learned worked best was actually having specific residents help translate. And that was their request. That wasn't our suggestion. So asking the organization to the point of what has made people successful or not successful before, how have people done in that location when they haven't spoken the language? And it can be one of a couple of things. Somebody can help translate. They really don't do well and you need a different fit. Or this particular group of people, often those who have had more education, may speak English and you might be able to interact with them, but you're going to be limited in interacting with these other groups. And that has or has not worked for these various reasons. There's no real one size fits all answer to that. Obviously, knowing the local language is 100% the best, but not always feasible.
So there's a detailed question about what one could expect to do on a day-to-day basis as a clinician, nurse, or doctor. And then what were some of these small victories that you're referring to?
Okay, so in terms of what to expect, it depends a lot on your role. And so if you are in a role that's really in that clinical educational bucket, then your role will be doing that. So you might spend, 3 or 4 hours a day on the wards or in the departments teaching, doing bedside mentorship, maybe some direct clinical care. You might spend a couple hours a day getting a lecture ready. You might give a lecture a different day. But it really will focus primarily around those clinical and educational pieces. If you are in more of an implementation role, which is a lot of what I do right now, frankly, I spend a lot of my time in meetings, but I spend a lot of time on planning and leading around what programs should look like and what are those various pieces to bring them together. So the IV infusions chart that we went through, that is something we are actively doing right now in Sierra Leone. And so a lot of what I do at this point is mentoring people who are there in terms of have we considered this, what needs to be done around this area. Here's a lesson we learned from somewhere else. Let's think about how to adapt this form or how to adapt this protocol. So it's a lot more on the planning side. It's a lot more on the sort of the doing of the actual program than it is around clinical care or education. In terms of like setting aside different parts of the day, I have done all sorts of different things. I tend to block time when I need like really dedicated thought time on something where I need to do like research back on an IV medication or something like that. And otherwise, for me personally, it tends to work best to just do as it fits with time zones and other things. And what was the other question? I'm sorry.
Well, the other was minor victories, but let me allow you an opportunity to give us the last advertisement. If people want to follow up with you and Partners in Health, do
Sure.
they email you? Do they try to give you a buzz? What's the best way?
Yes, people are always welcome to email me in here. I will drop my email address in the chat. So anyone is always welcome to email me. Depending on what your area of interest is within PIH, I may end up connecting you with somebody else. But always happy to try to answer questions or to get reach outs. And yeah, I would just encourage everyone to explore the wealth of different opportunities that are out there with different organizations and find what works for you.
So thank you very much again. This is exactly what we hoped would be communicated in this kind of seminar that we have, in which you enable graduate students and residents to move out and think about what this kind of a career would mean. It's a little difficult to find, and you're making it a reality for us, and we really appreciate that. Thank you.
Anytime. Thank you all.